You've seen this slide before from me. This is a randomized study of ozoroxine and a quinolone derivative anti-cancer drug. It was a negative randomized trial in the relapse setting. But among the 450 older patients who received ozoroxine with RRC as compared to RRC alone in the relapse setting, there was an advantage. And this has been maintained with the longer follow-up. And this is clearly beneficial in the older population as compared to RRC alone, both in patients who did or did not get allogeneic stem cell transplant following their response. But because of this, there has still continued to be some interest in ozoroxine. There was a phase 2 study conducted by Naval Daver here at MD Anderson, where he combined ozoroxine with Cytarabine in frontline therapy of older AML patients. I would not say these are not patients fit for chemotherapy, because I think of this regimen as a sort of a milder form of chemotherapy for this population. The response rate was high, and the responses have been durable, particularly when we reduced the dose of ozoroxine to 70 milligrams per meter squared on days 1 and 4. You can see the median survival is 16 months, which is, I think, is excellent for this population. There is a study similar to this ongoing, I believe, by one of the German groups, combining ozoroxine with azacitidine, and we'll hear more about that. Briefly on nucleoside analogs, clofarabine, as you know, we've had a lot of interest in this drug, and there have been a number of negative trials that have probably dampened a lot of enthusiasm about addition of clofarabine as well as other nucleoside analogs to the frontline therapy. This is a most recent trial published by the Hoven group in Blood that combined a more intensified 3+7 type regimen plus or minus clofarabine. And although addition of clofarabine was associated with reduction in the risk of relapse, it was associated with some increase in toxicity, which, as you see on the left side of the slide, led to essentially a negative randomized trial. But if you look at subset analysis, interestingly enough, in the ELN intermediate 1 risk group, which actually contains FLT3-ITD mutated patients, there was a statistically significant benefit for the addition of clofarabine to RRC and anthracycline induction. We have used Cladribine as well for many reasons. One, it is cheaper, and second, there was a randomized Polish study that added Cladribine to RRC and daunorubicin. And this is a regimen that we have been using as our frontline, again, led by Tapan Kadia in our group, where, as you see the doses there, we give Cladribine with what I like to call intermediate dose RRC and idarubicin. And again, this has been an effective strategy in our hands with an overall response rate of 85%, which actually has been durable. In the frontline setting in the blue line, you can see the median survival is over 18 months. And whether this will be picked up and looked at in any randomized trial remains to be seen. Clofarabine had another dagger on its back with this ECOG trial, the randomized trial of clofarabine versus 3+7 in older patients. Now, obviously, these are not older patients who are unfit for chemotherapy, because they are being randomized to receive 3+7 potentially. However, I find this a little bit of an unfair comparison, because in any cancer, we have always known that if you compare one drug to 2 drugs, you're probably going to do worse with the 1 drug, as long as there is some activity on the of the 2 drugs. But interestingly enough, the response rate was similar, but the study had to be closed because, as you can see here, the long-term follow-up was clearly in favor of the 3+7 standard arm. Following by this, and Dr. Federal in our group compared clofarabine and low-dose RRC to clofarabine a few years ago, and the combination was superior. So we have been using Cladribine low-dose RRC as induction in older AML patients that we don't want to give RLC and anthracycline-based induction. And we have done something else, and that's alternating it with hypomethylating agents, Cytarabine, in terms of consolidation, again, try to minimize development of resistance. And potentially in the future, we can add venetoclax to this as well. And this has been one of our major frontline studies in older AML. And you can see that the median survival, again, is quite respectable at about 13 months. The French group looked at clofarabine in another situation, and this is in the consolidation setting. So in this study, patients received a RLC and anthracycline-based induction. Patients who had a donor who were bound to go on to get an allogeneic stem cell transplant in first remission were excluded. The other patients were randomized to either high-dose RLC, the CALGB type, 3 grams Q12s on day 1, 3, and 5, or the CLIA regimen, which is clofarabine plus RLC. And despite, again, choosing the patients who didn't have a donor, some patients did go on to have allogeneic stem cell transplant in first remission. So as you see, the proportion of patients who did not undergo allogeneic stem cell transplant, there was a significant advantage for the CLIA regimen over the traditional high-dose RLC. At the top, the patients who did get the transplant really did not benefit from CLIA. But clearly, again, shows that these older agents can be potentially used in the specific situations and specific subsets and get some benefit. So despite my enthusiasm and everybody else's enthusiasm about new targeted agents, as well as monoclonal antibodies, I think the cytotoxic chemotherapy stays with us, at least for the foreseeable future. And some of these older drugs can be useful and can be resurrected with new strategies and potentially in specific subsets. Novel agents will, I'm sure, dominate our clinical trials in the next several years. Combinations of agents, FLT3 inhibitors, as well as IDH inhibitors are already in development. And prognosis in AML has improved slightly, but I'm sure you all agree with me that we still have a lot of work to do, and we need to improve the outcomes of these patients the same way as we have done for APL. Thank you.